really, before we even begin discussing, I do want to really take notice and say that harm reduction is deeply rooted in community, in particular, people with lived experience who want to help others. And as a person without lived experience, I want to acknowledge this fact, but also, try to approach this subject through the provider lens. And for those who may not have lived experience when it comes to speaking about harm reduction. So as such, I think this topic is geared toward the MOUD provider who would like to learn a little bit more about the foundational principles of harm reduction, and then how to kind of apply those into your practice of MOUD. So I don't have any disclosures today other than what we mentioned already. So we have 3 learning objectives today. The first is to define harm reduction, including the principles of harm reduction, and then briefly review the evidence that supports harm reduction as well. And then lastly, really demonstrate how you, again, as the MOUD provider, can apply harm reduction practically into your practice. So let's start off with harm reduction. And let's start that off by asking a question. It's getting a little bit warmer outside. It's nicer weather for sure. And many of us are spending a little bit more times outdoors. I'm going to ask the group, and you can text in the chat, or you can raise your hand, or you can just shout if you want to. When you're outside in the sun, do you guys use sunscreen? I see some people raising their hand. Yeah, I see a couple folks saying yes. All right. So I think the big thing about harm reduction is some people are like, I don't know how to approach this, right? Like, what is harm reduction? And I think for the most part, many providers may not realize that you actually talk about harm reduction a lot, more than likely, in your clinical practice. And sunscreen is just one of those examples, right? We know that exposure to UV light specifically can increase the risk for skin cancer, but being outdoors is really enjoyable for us, right? So we want to be outside. And we don't want to tell people, hey, stop going outside because your risk of UV exposure is really high and you can get skin cancer. So really what we recommend that they do is they minimize that exposure by wearing sunscreen. And that's really the essence of what harm reduction is. It's minimizing those negative health risks without completely eliminating exposure, right? And we do that in a lot of different things in medicine. Sunscreen's one of them. We may practice those same things with tobacco cessation, car seats, seat belts, all those different things we do here in medicine. We already doing when it comes to harm reduction. So that's kind of the way I define harm reduction, but what does the actual groups that, really practice harm reduction, how do they define it? And this is the National Harm Reduction Coalition. And they define harm reduction as essentially a set of practical strategies and ideas aimed at reducing negative consequences associated with substance use. It's also a movement for social justice built on a belief in and respect for the rights of people who use substances as well. There are really 6 core principles from the National Harm Reduction Coalition that also help define what harm reduction is. And those 6 include pragmatism, a focus on harm, emphasis on human rights, involvement of people with lived experience and people who use substances or use drugs, maximizing options, and immediate goals. So we're going to go through each one of these things. So what is pragmatism? I had to look this word up too, actually. So in simple terms, pragmatism is a way of thinking that focuses on practical results and solutions rather than kind of abstract ideas or ideals, really emphasizing what works in the real world. And I think that really sums up, harm reduction in a nutshell. In harm reduction, that means, for better or worse, substance use is part of our world, and we should focus on minimizing harm rather than ignoring it or condemning it. It also means that substance use is a continuum, and that there may be some ways of using substances that are safer than others, and acknowledging and understanding that as well. Harm reduction establishes that the quality of the individual, so how they're doing as a person, not completely targeting cessation, is really what drives success, right? So how does the patient define what their target of success is? It may be different from us as providers, what we may think, but it's really being patient-centered when we approach this and really focusing on the harms. But at the same time, like I said, it doesn't completely minimize or ignore those harms either from substance use. It acknowledges it, and saying from a safety standpoint, from a patient's guidance-centered standpoint, these harms exist, and what can we do to kind of help minimize those risks? As stated in the definition too, harm reduction really comes from this focus of human rights. And it really calls for non-judgmental and non-coercive service delivery. So really, there's no judgment in to condemn or support the actual use of substances. It's just there to reduce risk and support personal choice when it comes to substance use. And again, harm reduction involves people with lived experience and those who use drugs to ensure that they honestly have a voice when it comes to what's best for service delivery. And it's these people, honestly, that really drove the whole harm reduction initiative back when this was initially starting. And it's really about also, in the spirit of that, empowering people who use substances to support each other and really work with providers, not against them, to help figure out together what those best interventions will be to help reduce those harms. And then harm reduction, it shouldn't just be one or two things. It should be a plethora of things, really maximizing and providing a variety of options that are really tailored to the individual. And those can include safe supply, overdose prevention, et cetera. And we're going to go through all those things here in a minute. But you really should be trying to provide as many options when it comes to harm reduction. And in fact, if anything, harm reduction should not be isolated from medical services. It should be more so included and integrated into your medical practice. And that's what we're doing today. That's what we're learning about. So that's great. And then, really harm reduction, again, is about meeting people where they're at and establishing really achievable goals that they can aspire to and achieve. And then kind of working from the provider end to maybe build on those goals and maybe reach another goal down the line if the patient wants to do that. But it's really about meeting where they're at and meeting their immediate needs when it comes to providing harm reduction treatment. So what's great about all these principles that are from the National Harm Reduction Coalition is that they directly align with SAMHSA's principles of harm reduction as well. And they're aligned with the best practices that many of us use already for SUD treatment. So for example, the concept of providing support without judgment, that's directly related to patient-centered care, right? We should be practicing that. And what about practicing acceptance, right? Dr. Plum has talked about this before, but in trauma-informed care, that's a key principle when it comes to providing that. So, a lot of these things are kind of parallel when it comes to SUD treatment, and specifically harm reduction is in a direct alignment with what we're doing already with substance use disorder. It's just another piece of the pie, if you will, when it comes to treatment. And I think sometimes people think, is harm reduction really about enabling? And I think it's really important to talk a little bit more about that. Again, I'm coming from this as a evidence-based approach to treatment. And I think this a quote from Daniel Raymond, who I believe is the deputy director of the National Harm Reduction, really, emphasizes what I think the way to think about enabling is. And I'm just going to read this because I think it has such significance. I got into harm reduction to enable people who use drugs. I enable them to protect themselves and their communities from HIV and hepatitis C and overdoses. I enable them to feel like they have someone to talk to, someone who cares, someone who respects them and their humanity. I enable them to ask for help and to help others in turn. I enable them to find drug treatment and healthcare, to reconnect with families, to rebuild their lives. And I enable people who use drugs to take personal responsibility for their health and their futures. If that makes me an enabler, I'm proud to claim that term. And I think that's the way we should really be thinking about our perspective when it comes to harm reduction. We're really here to help people. We are not enabling them. We are not coercing them. We are not judging them. We are here to help patients who are asking for help. And I think it's important, again, we've talked about this topic before in some of our echoes, but, substance use itself lies along a spectrum, right? And it can go from no use all the way to substance use disorder. And even in between there may be perceptions of beneficial use from using substances as well, too. So it's important to understand that patients may have those same concepts as well when we approach them, or people who are, suffering from addiction. They may feel like their use is beneficial. And I think that's an important thing to understand, that it is part of the continuum of the substance use spectrum. But similarly, harm reduction also exists along a spectrum. We're going to talk about so many spectrums today, but it includes many components, and those can range from complete abstinence. That can be also part of harm reduction too, if that's the patient's goal, all the way just to kind of reduced use. So reducing their risk, or even safer consumption or safer use. Or some people may just want to completely stop their risk or reduce the risk of overdose. All those things are in a line of the spectrum when it comes to harm reduction. And I think thinking about all those different treatment modalities is really important for the MOUD provider. And I think lastly, I mentioned this previously, but we shouldn't isolate harm reduction in of itself. It is not just one thing. I used to think, and I'm guilty of this too, that I would probably just provide harm reduction resources for people that weren't interested in mood, right? So here's something at least to help you reduce your risk. But honestly, people who are on mood may want to reduce their use overall, but making sure that they're able to use their substances in a safe way is something that we should continue to help aspire them to. And therefore, harm reduction should be across the whole continuum, whether it's just prevention, intervention, treatment, or even after treatment. All of these things are really important when it comes to providing the best care we can for patients. And I think harm reduction is really integral, so it lasts along all the continuum as well. All right. I told you kind of about the definitions of these things. We're going to quickly describe evidence to support harm reduction. And again, I just want to make sure and reiterate that harm reduction itself is evidence-based, and that different types of harm reduction interventions are also evidence-based as well. And we're going to go through each of those things. So specifically, harm reduction has been shown to reduce overdose. So particularly when peers themselves, so people with lived experience, actually provide naloxone to other people that are using substances, there's been reduction in overdose deaths in that population, which is great. It's also been shown, as no surprise probably, safe use supplies can actually reduce the risk of HIV and hepatitis C. I think we're all aware of that. But there's actual data out there to show that syringe service programs, or SSP for short, previously historically called like needle exchange sites, those have been shown to reduce reductions in HIV and hepatitis C transmission as well. And relevant probably to this audience too is that those SSPs, they can actually do more services sometimes than just providing harm reduction. So those have been shown when they provide mood, that treatment engagement is better, and they even have even greater impact when it comes to hepatitis C and HIV reduction. So really important. A couple of other things that I think are important as well. So kind of harm reduction, kind of drug supply checking specifically has been shown to modify use. So specifically when people use fentanyl test strips to test their supply, they sometimes modify their behavior, and it's been shown to modify their use and kind of change their use to a more safer use consumption than when they're unaware of what they're using. So again, providing these materials helps, again, from a safety standpoint. What's great too is that these syringe service programs have also been shown when patients go there to get harm reduction. There's been increased treatment engagement when they go to these places because they actually refer people to treatment. So you may get people referred to your clinic from one of these places. So they're great to actually start people up on MOUD or other treatment modalities. And then lastly, I think also really great from harm reduction is that it actually reduces healthcare utilization. So there's evidence to support that, SSPs in particular have reduced healthcare utilization, specifically in ED visits and for hospitalizations around certain types of infections, specifically those related to IV substance use like bacteremia, endocarditis, those kinds of things. So there is literature out there to support interventions when it comes to harm reduction. So we've defined harm reduction. We said it's evidence-based. We said it's a patient-centered treatment. So Dr. Huerta, how do I actually do this into my clinical practice? And I think this is the really interesting part of the talk and how we can work on this together. So I think for mood providers, there are 4 key elements that I think you can start doing now to start practicing harm reduction. And that includes focusing on patient-centered care, reducing stigma, providing low barrier mood, and we're going to define what that is, talking about overdose prevention with your patients, and then going over safer use practices with your patients. So Dr. Plum, I believe, did another excellent talk on this topic, and I think just reiterate, I think it's important just to kind of touch here again, just to refresh that language matters, and practicing trauma-informed kind of care principles are integral into harm reduction. So making sure that we use, stigma-free language when we're talking to patients can really help set the stage and make them feel welcome and kind of open those doors to actually start talking. How would this look? How can we expand on patient-centered care? And how do we kind of use those things in practice when it comes to harm reduction? So these are just some questions that I use when I speak to patients that maybe you can model as well in your practice as well. So here's how I generally start the introduction. I want to make sure you get the best possible care while you're here, which is true. Is it okay? I ask permission if I ask some questions about your substance use. And then I ask them what their current goals around substance use are. It may not be abstinence. It may be reduction. It may be safer overdose risk prevention, those kinds of things. I think it's important to ask and bring the patient in when you're talking to them. If they say it's about reducing their usage, I ask them, how much would you like to cut back? It gives me a target. It gives them a target that we can work on together. And then what's been useful in helping you cut back in the past? Again, kind of building on things that we do naturally in our MOUD stuff. And then I ask them, are you interested in talking about medications like MOUD, overdose prevention, or even safer use? That's kind of the way I frame the initial conversation. Switching gears and talking a little bit about low barrier mood, which I think is really critical again to the providers on here. So what is that? So what is low barrier mood, people may ask? In essence, it's removing any barriers to providing MOUD to make treatment as easy and accessible as possible, right? So we know it's hard for people to even get treatment, to walk in the door. And why do we have these arbitrary additional barriers for them when it comes to getting medications? Specifically, we know, I'm preaching to the choir here with the mood echo, but MOUD is the gold standard of treatment when it comes to the treatment for opiate use disorder. We should make it really easy for people to get access to MOUD. So what are some examples of this? So number one, you should offer MOUD on the first visit when you see somebody, right? We shouldn't make them come back the next day. We shouldn't make them come back the next week. We should not delay treatment when it comes to getting access to these life-saving medications. This also means that behavioral interventions, specifically like counseling, should be offered to patients, right? Because they are beneficial, but they should not be required for MOUD access, right? So saying that they have to attend counseling in order to get a prescription, that's really not in alignment with making sure it's as easy as possible to get medications. Also, we know that as MOUD is the gold standard, it should not be stopped if patients are using other substances. So that's another key thing I just want to rephrase here. So if people are using other substances like methamphetamine, for example, I've seen in practice, sometimes providers kind of withdraw treatment with buprenorphine in those cases. If anything, if buprenorphine is especially working for that patient, you should continue to make sure that they're getting their medication and that it's not stopped for other things. I always say this to people too, I am treating opiate use disorder with buprenorphine. I am not necessarily treating methamphetamine use disorder with buprenorphine, right? So that's the goal of treatment when it comes to these things. And then in alignment with what we've just been saying and in alignment with harm reduction, abstinence may not be the goal. And reduction in substance use itself and safer substance use are acceptable treatment goals. So sometimes people will say, they're still coming in, or providers may say, this patient's still using while I have them on buprenorphine. Well, are they using less? Is that part of what their goal may be? Again, working together, it doesn't mean that MOUD should be stopped, if anything. If anything, it means that more additional things should be offered to that patient to help support them in their recovery. And I think a critical component of all that, in summary, if you had to take that away as far as low barrier mood, on the provider level, you want to celebrate any positive change that reduces harm, right? So what that means, hey, doc, I reduced the amount of fentanyl I've used by 1 pill. That's a great celebration. You need to celebrate that and encourage them. If they said, you know what, I'm completely abstinent, that's great too. But all of the things, really celebrating each of these steps along their journey is really important for them when it comes to this. And that's directly aligned with what the harm reduction principles are. All right. So what about overdose prevention? And I know it can be a little bit, I want to acknowledge this too, because it can be a little bit of a taboo subject for some providers to be discussing things that you're not completely familiar with or trained on, and that's okay. I think when I first started doing these conversations, it felt a little bit awkward as well too, recommending these interventions that I'm about to speak about, but it does become part of essentially the clinic culture, your culture as well too, the more you do it. And I will say patients are really receptive to me now that I've been doing this for a while, and they're receptive when I first started too, because they know that you're coming from a place of help and encouragement. So what are some of those examples that I'm specifically talking about? So when I talk to patients about overdose prevention, I specifically say these things. Try not to mix different substances together. And if you do, try to use less, right? So if someone's using benzodiazepines and opioids, for example, and I know they're still working on trying to reduce their benzodiazepine use, I try to at least tell them, hey, please don't mix those substances together when you're doing them together. At least can you separate them out a little bit, again, to help reduce overdose, right? That's the whole goal of here, to help reduce harm. I also tell them try not to use alone, or if you do use alone, make sure you have somebody there. Try to get a friend with you, or I share the resources for the Never Use Alone hotline, and we're going to go through that here in a second too, what that specifically is. I also tell them if it's a new batch of substances that they're using, why not try a test shot or dose before you actually do what you normally do? If someone uses 10 tablets of fentanyl at a time, for example, and they got a new supplier, a person who's supplying them with things, I tell them, hey, try 1 tablet before you try the 10, just to make sure it's not a bad batch and there's something else in there. I also try to tell them, hey, if you have somebody there who's available while you're using, try to develop like an overdose response plan. So what happens if this happens? Do you have Narcan on hand, for example? Who do they call? Do they call EMS? What happens? The other thing we talk about is alternative forms of routes for use of substances. So for example, if someone's using intravenously, there can be more risk than compared to insufflation or inhalation. So we can talk about that as a way to help reduce risk when it comes to substance use. And then, of course, obviously, I think a lot of us know this, but we go over naloxone education as well. Not only provide it, but we give them sheets on what the recognition of an overdose is, what the typical response should be, and what the reversal agent, how it works, should be. And we do this in a very kind of simple to understand methodology as well. So I mentioned this is the Never Use Alone website hotline. This is 877-696-1996. So what is it? You call this number, you tell them your name, and you tell them where you're at, and you use, and they'll check on you after using. And if you don't answer back after a certain period of time, they will call EMS for you to make sure that you are rescued at that point. So it is a way to help make sure that people don't overdose when they're using alone. And this is a federally funded program, I believe. And I hand these out to patients all the time. I say, here's a number, think about it. A lot of people are aware of it, but it's great if they're not, to make sure that they are aware. This is a great handout from the New Mexico Department of Health. And by the way, all these handouts will be at the very end. So you can get all the, you go to the websites and you'll be able to find these. This is a really it's a really nice handout we give to all our patients here, how to respond to an overdose. It talks about what the ABCs of an overdose are, again, from a patient level, how to use naloxone, and how to perform rescue breathing as well for people. So that way they have it on hand when they actually, if anything were to happen. All right. Next is safer use practices. These are, again, with IV substance use specifically, primarily. And again, I'm acknowledging this may be a little bit taboo for people, but these are just some examples of how to educate patients on safer IV substance use. So here are some things I mentioned. Try not to share needles or equipment. Try to use sterile water when preparing your shots. Clean your site if you're able to before injecting. Do not lick the needle before injecting. If the shot starts hurting when you're injecting, pull it out. Try to rotate the areas where you're doing these shots to help reduce infection risk. Try to inject bevel up so that way that bevel doesn't get corroded over multiple uses. Take turns if possible, and have naloxone available again for that overdose. So these are some practical things you can ask or say with people. I know, again, it can be challenging or somewhat awkward to say, but I think it does help out with patient-centered care. Safer use supply, so syringe service programs. These are great. And like I mentioned before, they provide sterile syringes. They do safe disposal of syringes as well too. They provide overdose education, etc. And some of these actually do a little bit more than that. They can do wound care. They can actually do testing and vaccinations there, and they can help link people to care. So I think that's a great thing to do. There's a great website, again, links at the end. Here in New Mexico, you actually go to this website, you put in your zip code or city, and you click on syringe service program, and it will find the nearest one to you. So you can actually say, hey, where do you live? And if someone's using intravenously or just you want to send them there, you can say, hey, here's one over here on this corner over here, and they're open from this time to this time. It really helps out. Another thing you can potentially do to help educate people is go over fentanyl test strips. We have these flyers at the clinic as well too. We hand these out again from the Department of Health. Maybe spend a few moments when you're seeing with them. Here's how you check it. This tells you here in quick 6 steps on how to do that. It's not complicated how to read and interpret those results to make sure that their supply is safe. And you can also do that for xylazine as well. They have these test strips there, and you can provide education for them moving forward. The other really cool thing that which Dr. Ward may be able to more and talk about is can educate patients on, can actually submit their supply in an anonymous way to the state for drug checking. So if they're so interested, they think there's something, relevant in their supply, they can actually submit those drugs to get tested. And what's great, I think, is that this drug testing helps guide treatment too. So there are reports that come out and say, here's what's contaminated in the supply in New Mexico and those kind of things. So it does help providers understand what's going on in the field as well. And then you could also consider handing out supply kits. These are examples of some safe use kits. This is from the ABQ Punk Safety Initiative, which is really cool. It's a group of medical students that really set up this harm reduction initiative, and they go to concerts and stuff. So shout out to them. But the caveat about this is that you have to actually get trained in a certificate from the Department of Health in order to do this. It's a couple-day training. I'll show you where and how you can do that. You join a mailing list and you do this training. And after that, guess what? You can actually hand out these kits at your clinical site too, if you so feel empowered. So this would be like the next level when it comes to things. And these are just examples of this. And for the sake of time, I'm going to run through just these pictures. And lastly, if you want to know more about harm reduction, again, all these resources will be at the end. The Graken Center for Addiction has a great YouTube channel that actually goes over many of the kit pieces itself and how patients can safely use them. They're like 5-minute little interview clips. You can run through them with the patient. You can hear about them yourself, educate yourself on these. They have about 10 or 20 of these videos, which are really cool and really helpful. So again, here's the link. I think Rachel will send this out, but you can find the SSPs where they're near you. You can get all these educational pamphlets that I went over with people. You can also look up naloxone availability. There's a website that you can get free Narcan at your clinic. There's also a helpline there, 833-796-8773. You can call them and they can work with you on how to get Narcan at your clinic. I mentioned those YouTube education channels. If you're interested in getting harm reduction certification, here's the link. You want to go to the bottom and scroll where it says join harm reduction mailing list, and they'll get on the list and they'll tell you when those trainings are. And then if you want to work, another option would be working collaboratively with community organizations. There's a great non-for-profit harm reduction group here called the New Mexico Harm Reduction Collaborative. And they can also go to your place and hand out clinics or hand out kits and stuff for you too. So really, I think there's a lot of things you can do as a provider to start implementing harm reduction into your clinical practice. So really, in a nutshell, harm reduction helps reduce the negative impact of substance use while respecting the rights and dignity of people who use substances. It's evidence-based, been shown to reduce overdoses, infections, and healthcare utilization. And it can be really practical to implement into your practice. And there are some resources here to help you along the way. And of course, us on the ECHO team here would love to help you in any capacity that we can when it comes to this. So thank you so much for listening to me today.